Chapter 39 is going to cover hazardous materials, multiple casualty incidents, and incident management. Hazardous materials by the textbook is defined as any substance or material in a form which poses an unreasonable risk to health, safety, and property when transported in commerce. And that's the definition by the U.S. Department of Transportation. That's the definition you'll need to know for examinations and for the textbook. Understand that the world is ever changing, so there's always going to be new hazardous materials that are always coming out. Use your resources the best you can. Understand the ERG book, utilize the internet, whatever resources you can if you're put in a situation where you could potentially be exposed to hazardous materials, and use those resources to know what threats you have, how to take care of your patients. There's actually a class for specifically to hazardous materials that should be required for most EMS agencies at the hazmat awareness level, and then there's multiple levels up beyond that. It's always good, even if it's not required, to take that hazardous materials awareness class so that you do have a better understanding, because your EMT basic textbook is just going to touch on it. It's not going to go into nearly the depth that that hazmat class would go into. The two agencies that are going to kind of dictate the rules for hazardous material situations are going to be the EPA and OSHA, Occupational Safety and Health Administration. As I mentioned briefly in the last slide, at the EMS level, you're probably going to be required to get a first responder awareness level certification. It's a short class. I believe it's 8 hours. It entails basically how it sounds. They're trained to recognize the problem and initiate the response from the proper organization. So you're going to get there, you're going to look at it, you're going to say, yep, it's hazardous materials, and that's going to be just about it. Now, there's other levels beyond that, with the first one being first responder operations. Now, these people are going to be able to initially respond to the scene, but they're going to stay at a safe distance, keep the incident from spreading, and then protect others from exposure. So again, kind of not in the mud of the hazardous material situation, but more in the protection mode of the hazardous material situation. Next level is going to be the hazardous materials technician. This level is for the rescuer who actually can plug, patch, and stop the release of the hazardous material. A minimum number of hours of training is going to be required for this level, and then you kind of build on each of these levels. So then once you get past hazmat technician, the next one's going to be specialist. They're going to be expected to have a more directed or specific knowledge of the various substances that the rescuers may be called upon to contain. The role is going to allow the specialist to act as a site liaison for federal, state, and local and other governmental agencies with regard to the site activities. And then the final position here is going to be the on-scene incident commander. This level of rescuer implements the incident command system and all applicable emergency response plans to control and manage the hazmat incident. Moving into the responsibilities of the EMT and kind of what your role is going to be, first and foremost, recognize the hazmat incident. Understand that depending on where you're located, it could be anything from a delivery truck to a chemical plant to a train derailment. It could be any of these items listed. It could be anything beyond that as well. I've always been told that it's more concerning for, if you have a tanker truck go over, it's going to have one chemical in it. If you have a Walmart truck go over, it may have dozens of different hazmat materials in there depending on what they're transporting. So don't get caught off guard when you get on scene. When in doubt, always assume that it's going to be a hazmat incident until somebody tells you otherwise. The other thing that you need to do is understand that patients leaving the site, they need to be considered contaminated until proven otherwise. It's a challenge from an EMS perspective because you're trained to get to the scene, go in and help the patients. When it comes to hazmat scenes, it's a little bit different because you don't want to put yourself in harm's way. Again, scene safety always comes first. So you don't want to put yourself into something that could contaminate you or potentially kill you. You have to have restraint, stay back until you get the all clear or until the patients come to you, depending on the situation, so that your safety comes first. If you're the first responding unit that arrives on scene, your first and most immediate item that you need to take care of is controlling the scene. So the first thing that you'll need to do is establish where the danger zone is and where the safe zones are. So the danger zone is going to contain two separate areas kind of within that zone. The first one is going to be the hot zone. That's going to be the area of contamination, the area of immediate danger. And then beyond that, the area directly adjacent to that hot zone is going to be the warm zone. It's going to be kind of the area where you have the decontamination corridor. What you want to do is establish what those areas are and then create a safe zone or a cold zone where equipment and emergency rescuers are staged. Now with the safe zone, you want to be on the same level as and upwind from the incident site. Avoid being downhill in the case that there are flowing liquids or gases. Avoid low-lying areas because those fumes and other things like that are going to kind of funnel down into those low-lying areas. Avoid being downwind of the scene so that you're not in the path of escaping gases. Also be aware of the sewer system and where it can take the hazardous material to. Utilize all of the resources that you have, and then when somebody gets there that's at a higher level of you, then you're going to kind of transition over the entire scene to them, and then your job becomes more of an EMS role, and you're going to do as you're told at that point. Once you have that initial step of the scene management taken care of, the next step, if you're still there alone, is to identify the substance, if possible. Remember that anytime that you go to a scene and you have multiple patients, start thinking, why do I have multiple patients, especially if it's unexplained reason. Obviously, if it's a car accident, it's a car accident. But if you go to a business and there's 4 people with nausea and vomiting, your mindset should kick in and say, why do these people all have the same symptoms? Is this a hazmat situation? Is this a fire scene? What's causing the issue that multiple people have the same kind of signs and symptoms of what's going on? So the first thing would be to assess the material and the severity of it, determine it may change a little bit those initial steps of controlling the scene with the danger zone, the hot zone, the safe zone, because you may enter what is the hot zone not knowing it, and then you got to pull back, keep people out of that situation. So try to identify it and then use your resources, your ERG book or the internet, so that you can get more information on what the substance is. The next thing to do once you're at a safe distance, you have your zones set up, you've identified the substance. How do you go about identifying that substance? So first thing is, if you have to use binoculars, look for anything that can identify it, such as signs, labels, placards. Hazardous materials are generally going to have some sort of placard on them that's going to be a diamond shape. There's a couple different things to look for here. There's going to be 4 different colors. Blue is going to cover the health hazard. Red is going to cover the fire hazard. Yellow is going to cover the reactivity. And white is going to cover the specific hazard. There's also going to be a number attached to the health, fire, and reactivity. And the higher the number, the more dangerous the material is going to be. Look for labels, look for invoices, any sort of billing paperwork, shipping manifests. Hopefully there's an employee there that can also assist you and point you in the right direction to get any information that you can that's going to be useful. If you're able to get them, utilize the SDS, or otherwise known as the MSDS. It's the material safety data sheets. Any business, industry, whatever the case may be, they have to have these MSDSs for basically every chemical that they have, any hazardous material that they they have to have these sheets, and it details what the chemical is, tells you what the dangers are, tells you what signs and symptoms to look for for an exposure, and gives you some of the treatment guidelines. So they're going to be very useful. However, you're not going to know where to go look. Hopefully, there's an employee there that's going to be able to assist you with this. So interview the workers and others that are leaving the hot zone that are hopefully not contaminated so that they can give you any information on this hazardous material. The other thing that we've talked about previous slides is the ERG book, which is the Emergency Response Guidebook. It's basically going to cover a lot of the same information that the MSDSs are going to cover. It's just in a handy book. It's going to also go through the placard information that I talked about with the different colors and the different numeric values to explain the dangers of all of those. Another expert advice that you can utilize is what's called Chemtrec. It's a Chemical Transportation Emergency Center. And basically, it's a group that can provide you information. There's actually going to be a toll-free number that you can utilize to call them. If you want a comparable to it, it's going to be like calling the poison control number for somebody that ingested a poison. This is basically the hazardous material number so that you can get information on a specific hazmat incident. A few more areas that can provide you assistance is Chemtel Inc. It's also going to have a toll-free number. It's basically going to be similar to the Chemtrec in that they're going to be able to give you information. Understand where you might be able to find a current list of state and federal radiation authorities so that you can get information on that. I know for us, there's a chance where we reside that you could respond to a nuclear power plant. So things are a little bit different in that area. So utilize your resources there. Also, understand that Poison Control Center is going to be a good resource for this as well. You can always call the Poison Control Center, tell them what they've been exposed to, and they're going to be able to help you through the process. Regardless of who you're calling, make sure that you're giving them your name, your agency, and a callback number. Kind of explain the nature and the location of the issue. Give them any information on the material that you might have. Give them the name of the carrier, the shipper, the manufacturer, basically any information that you can get. Describe the container, report what kind of container it is, try to estimate how much of the material's been released, report any of the injuries or exposures, report that local emergency services have been notified, and then keep those lines of communication open at all times. Like it said, make sure that they have a callback number so that way if you get disconnected, they can get back a hold of you if they have any more information. The next piece that the EMS is going to be a portion of is going to be establishing this treatment area. The first thing that you're going to want to establish is a rehabilitation operations. So understand that you're probably entering a phase utilizing the incident command structure. So there's going to be an incident commander, and then there's going to be segments off of that. You're going to be part of the EMS segment that's going to have multiple responsibilities. Kind of the tricky part is that they're going to appoint somebody called the rehab supervisor. And it may not be an EMS provider. Now, there needs to be EMS personnel within the area, but they may have somebody else managing the actual overall zone that the EMS is going to be a part of. So with the rehab operations, you're going to be taking care of primarily the hazmat crews that are going in and coming out. You want the rehab operations area to be located in the cold zone. You want it to be protected from weather. It needs to be large enough to accommodate multiple rescue crews, so it's not going to just be the back of an ambulance. More than likely, you're going to probably get tents, some sort of structure, could be a nearby garage that's in the safe zone. Whatever the case may be, it needs to be large enough that it'll accommodate everything that you might run into. It needs to be easily accessible to EMS units. If you have somebody come out that needs to be transported to the hospital, you want it to be easily accessible so that an ambulance can come in, pick up the patient, and get back out without really interfering much with the operation that's going on. Free from exhaust fumes, you don't want to create another hazmat area, and then allow for rapid reentry into the emergency operations. So you want it to be far enough away to be safe, close enough that once they're through the rehab process, they can go back to the working process. Now we'll talk a little bit about the care of injured and contaminated patients. So understand that anybody that comes out of the hot zone, they're going to go first into the warm zone where they're going to get decontaminated. Now, in your textbook, there is an example of a field decontamination process. Take a peek at that. It's a 9-step process. Kind of explains what they do to get through the decontamination. And then once they are decontaminated in the warm zone, they're going to be moved to the cold zone for further treatment. Understand that field decontaminated patients are not completely clean, so you still need to utilize personal protective equipment and clothing to prevent secondary contamination of yourself and your coworkers, the other rescuers around you. So just because they've gone through the decontamination process doesn't mean they're completely clean. You still need to utilize all the safety mechanisms so that you can keep yourself out of harm's way. With the decontamination process, a couple more things to think about is to protect your vehicle or your area from contamination. So when they go through the decontamination process, they're going to get washed somehow. A lot of times it's simply a fire engine that hoses them down. So now when they're dripping wet, any of those fluids that might be dripping off of them could potentially be contaminated. So you need to either make sure that they're dry and they're not dripping, or if they are dripping, that you utilize something to protect your area, whether that's a small plastic pool that they can stand in that collects all that liquid. Now that liquid becomes its own little hazmat area that needs to be taken care of down the road. But you can utilize that, make sure that you have plastic over the flooring of your ambulance if you have a patient back there, whatever the case may be to protect your vehicle. You may have to consider some used equipment as disposable. So depending on what gets contaminated, it could be something as simple as a blood pressure cuff or a stethoscope, maybe a long spine board. Anything that comes in contact with the patient, there is the potential that it has now become a disposable item and it's going to have to be thrown out and replaced. Hopefully your agency has plans in place to take care of this. As far as firefighters go, their structural firefighting clothing is not designated for use when working in hazardous material. So if there's a fire and firemen go in there with their regular turnout gear on, there's a chance that they've just ruined that turnout gear, because if it gets contaminated, it might not be able to become decontaminated. So understand that basically anything that has come in contact with what the hazardous material is could become contaminated, and it could eventually basically become disposable. You're going to have 4 types of patients that are going to come to you through this process. They're going to be either injured or uninjured, and then contaminated or not contaminated. So you might have an uninjured but not contaminated patient. You may have an injured and not contaminated patient. Those are going to be the simplest because they don't have to go through a decontamination process. You can either just assess them and get your refusal, or you can assess them, treat them, get them transported. No big deal. And then you might have an uninjured and contaminated patient or an injured and contaminated patient. So these are the patients that are going to have to go through the decontamination process. If they're uninjured, they're probably going to come to you for some sort of assessment just because of the scene that you're on. If they're injured, they're going to get deconned, come to you, get assessed, and then have some sort of transport, whether it's you or if it's some sort of big incident, you may have a line of ambulances that you kind of shuffle them through and put patients in them as they basically become available. So these are the 4 types of patients that you're going to be potentially taking care of. So if you arrive on scene and you're confronted with a contaminated patient prior to the hazmat team arriving, um, basically what are you going to do? Well, these are kind of the steps. First thing is take precautions appropriate to the substance that's listed in the ERG. So pull that ERG book out, find the substance, and read that page so that you understand what precautions you need to take. And then you will also understand what first aid measures you need to take. Manage the patient's critical needs. So it doesn't matter what the patient is, what the situation is. We learned about this way back in the assessment chapter. ABCs are first. They're part of that initial assessment. Nothing else matters if they're not breathing, have patent airway, or they don't have a circulation. Those are going to kill them regardless. So it doesn't matter if they've had their leg ripped off and it's contaminated with the most god-awful substance that you can imagine. You got to take care of the ABCs first. If treatment calls for irrigation of water, remember that that water only dilutes most substances. It doesn't neutralize them. Also remember that if you're putting that water on to the contaminated whatever it is, that flushed water now becomes contaminated itself. So try to contain it, catch it in some sort of basin, whatever you have to do so that you're not contaminating everything around you. After you treat the patient, decontaminate yourself. You may need to dispose of your clothing and go to some sort of, hopefully you have like coveralls or something in your ambulance that you can switch to in that situation, but you may become contaminated yourself and you may potentially have to go through a decontamination phase. For your purposes, there are basically going to be two phases of decontamination. There is a third phase, but it usually takes place further down the road at the hospital or someplace where they're beyond the EMS care. The first phase is going to be the gross decontamination. This is going to be where you're removing the bulk of the chemical, uh, however it comes off, whether you brush it off, whether you wash it off, but it's just getting the bulk of it off with the understanding that there's probably going to be some residual left on that host patient. Then you'll go through a secondary decontamination where it's more thorough. You're hopefully going to get most, if not all, of the residual product off of the patient. There are going to be 7 common mechanisms for performing decontamination. The first one is emulsification, and this is going to be the production of a suspension or ordinarily immiscible insoluble material using emulsifying agents such as soap or a detergent, something else to help with the decontamination process. The next one is going to be a chemical reaction. This is the process that neutralizes, degrades, or otherwise chemically alters the contaminant. Normally, this chemical reaction does not ensure that all hazards have been eliminated, and reaction procedures can be both difficult and dangerous to perform. So chemical reactions is therefore not recommended for use on live tissue. This is going to be something that they'll utilize someplace else, more than likely not with your patient. Disinfection is going to be the process that removes the biologic contamination hazards as the disinfectant destroys microorganisms and their toxins. Think of any disinfectant you use to kill bacteria wiping down your counter. Basically, it's that process. Dilution is going to be kind of like it sounds as well. It's the process where you simply reduce the concentration of the contaminant. It's most commonly used for substances that are soluble. Large quantities of the solvent may be required to dilute even small volumes. So depending on what the chemical is, it may take a lot of fluid to actually take care of the issue. The next one is going to be absorption or adsorption, and this is going to be the penetration of a liquid or gas into another substance. So water soaking into a sponge. Think of it like that. The next one will be removal, and it's the process of removing contaminants by pressure or vacuum. Most efforts involve the use of water, so like we talked about, they might set up a fire truck, use copious amounts of water, wash you with their fire hose. Those solids can be removed with brushes and wipes, and sometimes even air can be used depending. So a compressor with a little air gun on the end of it to blow it off. You just have to keep in mind where it's being blown to, that you're not contaminating something else. And then the final mechanism is going to be the disposal, and this is the aseptic removal of a contaminated object from the hosts, after which the object is disposed of. So those are going to be the different mechanisms for decontamination. The procedures that you're going to want to use, basically these objectives are going to be to determine the appropriate level of protective equipment based on the material and associated hazards. So you have to know what that chemical is, what the hazardous material is, and then you can start figuring out what you need. Always wear your PPE, properly wear it, operate in it. Don't take it for granted. Understand that you don't want to be exposed to something that could be dangerous to you, or that you could potentially then down the road expose other people to. Establish an operating time log. So it's going to be important. You're almost going to want a scribe with these situations, somebody that can just take notes and log everything as you work your way through it. Set up and operate the decontamination line. So it's kind of a systematic approach of, we start at A, we move to B, we move to C, as they work through the decontamination process. And then prioritize and decon the patients according to a triage system. So you don't want to have to wait on 5 green patients, which are going to be the least injured, to get to a red patient that's the most injured through the decontamination process. You're going to want to get all of your most severely injured or sick patients out first, and then work your way backwards to the ones that are considered the green category. You're going to need to be able to perform the triage in your PPE, and it may be as simple as gloves. It may be something like gloves, gowns, booties. It could be a full-on suit. It's whatever that chemical is going to dictate what your PPE is. You're also going to need to be able to communicate in that PPE. So if you do end up in a suit where you have to have your face covered and everything else, you need to be able to make sure you can communicate. Some of the basic equipment that you might need, and hopefully that, if you're part of a hazmat team, you're going to go through more training to understand this better. However, if you're thrown in this situation and you have access to some of this stuff, some of the basic equipment you're going to need are buckets for water to collect water, brushes to help with the decontamination process, some sort of decontamination solution, decontamination tubs that can kind of hold all of the contaminated fluid. You're going to want a dedicated water supply so that you always have water for the decontamination process. You're going to want tarps or plastic sheeting to protect things from becoming contaminating. You're going to need a containment vessel for any water runoff. You don't want it running into the sewer system. You don't want it pooling where people are walking through. And then you'll need a pump to transfer that wastewater from the decontamination tubs to the containment vessel. So this is like really further down into the scene management. This isn't going to be a short process. An A-frame ladder can be useful to reach the top of the responders' suits, and then appropriate level PPE for responders performing the decontamination. Now we're to the point where you're thinking about decontaminating the patient who's been wearing the PPE. So they're going to be mostly protected on the inside, but they still need to go through a decontamination process. So you want to rinse them starting at the head and working down, kind of like showering. If you start and you wash from the bottom up, all that dirty runs down your body, and then you basically just got dirt on the areas that you've cleaned. Same thing with this. You want to wash the chemical from the top down so that you're not contaminating something that you've already cleaned. Scrub the suit down with the brush, starting at the head, working down, same mindset. Rinse again, starting at the head, working down, same mindset. and then assist that responder in removing the PPE. Try to keep it so that they don't come in contact with anything on the outside, basically like how you learned how to take gloves off and you peel them back so that the dirty becomes the inside part of the glove. Anything that you can take off, that you can put the contaminated portion inside of itself is what you want to do. And then you need to contain any runoff of hazardous wastewater. So you need to somehow, whether they're in a tub or you have some sort of pooling system set up so that all that contaminated water goes to one place and then it can be pumped off later into that containment vessel. And then the final thing we'll talk about is decontamination of the patient who's not wearing PPE. This is going to become a little bit uncomfortable for your patients because they're basically going to have to go through a strip down process. So your first consideration, as always, is your responder safety. Next thing that you want to do is make sure anybody that came in contact and needs to be decontaminated, that you use some sort of communication. You may have to use a public address system if it's a larger venue with a number of people to direct ambulatory patients to the decontamination line. Once there, they're going to have to remove their clothes and remove their contact lenses as soon as they can. So they're stripping down to become stark naked so that they can go through this process. So understand that you're going to have modesty to deal with, embarrassment for the patients, but it is part of the process. Double bag the clothing, tie it up, label it, and then set it aside. Then you will decon each of these individuals for a 2 to 5 minute water rinse starting at the head. Now, if they have a chemical on them that might react with water, you're going to want to blot all that material off first before you rinse them off, and then send them through this 2 to 5 minute water rinse cycle, basically. Again, keeping in mind some sort of containment area for any of the runoff with the water. Once that's done, provide the patient cover for modesty, whether it's a blanket, maybe you have bulk drapes that they can put on, whatever the case may be, and then you move them into the next step. With hazmat scenes, understand that it's not a quick process. It's going to be a very slow, methodical process. Your first priority as an EMS provider is care of the critically sick and ill, and then you work your way into these other processes. So that if you're part of a decontamination team, you're talking, it's not just a few minutes and you're going to be done. This is going to be hours, perhaps days, to sometimes get through the process. So it's a little bit different than the normal call. I would highly recommend going through a hazmat awareness class so that you have a better understanding of hazardous materials, how to deal with them, how to recognize them, how to identify them, and then how to take care of the people that might be exposed to them. Now we're going to move into multiple casualty incidents. And a multiple casualty incident is going to be when your resources are expended. So depending on your agency will dictate what is constituted as a multiple casualty incident. It might be 3 patients, it might be 6 patients, it might be 10 patients. It just depends on the situation. So they're going to range from small to large, and they might last anywhere from less than an hour to days to weeks to months to years. So you might have, a 3-vehicle accident with 8 patients where you have multiple ambulances coming in. That's considered a multiple casualty incident. You may have something like Hurricane Katrina where you have hundreds of different agencies coming in. That's also considered a multiple casualty incident. Both of them are similar, but they're different in the same sense. The end goal is going to be the same. How you get to that end goal is going to vary depending on the situation. If you work someplace that has a known local disaster plan, Know it and understand it. A disaster plan is basically going to be a predefined set of instructions that tell the community's various emergency responders what to do in specific emergencies. Although no disaster is really the same, can be um, everything is going to be kind of situational. You can kind of address every problem that could arise basically from this plan. The disaster plan should be written to address the events that are conceivable for a particular location. So Kansas needs to plan for tornadoes. Illinois needs to plan for tornadoes. We live next to a nuclear plant. You need to plan for something that happens there. Florida needs to plan for hurricanes, and so it's kind of regional on what your disaster plan may entail. It needs to be well publicized. Each emergency responder should be familiar with the plan and how to put it in operation. It needs to be realistic in the aspect of the plan must be based on what the actual available resources are. You can't put a bunch of things in there that you don't have access to. So that plan needs to be what you can get, what you have access to, and then how you can take care of the situation. It also needs to be rehearsed. Experience is proven that it's the only way to get a plan to work correctly and to exercise it. So in doing so, you can work out the unforeseen bugs. This disaster plan might be written, and then once you actually go through it once, you may alter it and have to make changes to it because, hey, this didn't work, this didn't work. This worked really well, but it needs to be moved up to this area of the plan. So it's going to be evolving every time you have an incident. Some things are probably going to change in it. Anytime that you have a mass casualty incident, you should be utilizing the incident command system known as the National Incident Management System. It's NIMS. And I will create someplace else in the Teams network the information on the NIMS system. But there's different levels from 100 to 800 and beyond. Commonly, you guys as EMS providers should get the certification of the NIMS 100 and the NIMS 700. The NIMS 200 and the NIMS 800 are also useful. 300, 400, 500, 600 are going to be more command type settings. So you may need to get those down the road depending on what your position is. But the first position in the command is going to be the command. And then from there, they're going to delegate individuals to oversee different areas such as operations, planning, logistics, finance. And you may work in a single incident command structure or a unified command structure. If this is a short-lived car accident with a number of patients that's not going to last very long, it may be a single incident command system. If it's a larger issue such as a hurricane, you're going to use a unified command system in which everybody works together. If you are the first on scene at one of these incidents and you are the most senior member, then you should assume the position of incident command and start the process from there. Now, once reinforcements have arrived, there are a couple different paths you can take. If you have the knowledge and you're comfortable with it, you can continue to be in command. If there's a higher ranking official or somebody shows up that you know has more experience, you can transfer that command to someone of a higher rank, and then you're basically going to get recirculated back into a different position, whatever suits you depending on the situation. So you arrive on scene, you establish the incident command. The next thing that you want to do is a quick walkthrough of the scene to assess the number of patients, the hazards, and the degree of entrapment. Now you need to figure out, and it's a short process, what resources you're going to need. Once you've developed what resources you need, then you need to be calm and composed, get on the radio, with the initial scene report and call for additional resources. So you may give a scene size up over the radio so that incoming units know, hey, we have a school bus on its side, multiple kids in and outside of the vehicle, and then let your dispatchers know, hey, I need X amount of ambulances, I need police, I need whatever the case may be. That's going to be the determination you're going to make. It can be evolving through the situation, so you can always add to or subtract from. Always err on the side of caution. It's always better to get too many coming than not enough. You can always cancel. But like I said, it's ever evolving. We discussed already, give that brief report, request the necessary resources. As your reinforcements arrive and you start divvying out different positions, if you remain in command, try to have face-to-face conversations with that command staff whenever possible so that's nothing's missed, and then they take the information back out to their team that has been assembled for them to work with. And then in these situations, it's going to be best if whatever radio you have or use, whether it's a VHF or some other fancier radio, hopefully you have multiple channels that you can utilize so that you can go to a working channel on the scene so that everybody can communicate as needed on scene. And then it's ultimately going to be the incident commander is going to be the only person that converses with the communications center and disseminates the information out to the others. So you don't want the transport coordinator calling and saying, hey, I need 5 more ambulances to the dispatch center. And somebody else walks over to you and tells you you need 5 more ambulances. And then you as the incident commander call and say, hey, I need 5 more ambulances, because now you might be getting 10 ambulances. So everything filters up through the incident commander, and then they are the ultimate communicator as to what's coming onto the scene. These situations are going to test your organization skills, and organization is extremely, extremely important. Early and aggressive organization is going to be vital to the success of this scene. Have a plan to deploy the resources. For example, in Illinois, we use a system called MABUS. So I know that when I get on scene at a multiple vehicle accident, I can call for a third alarm EMS response to this scene, and I know exactly I'm going to get 6 ambulances and a helicopter because it's pre-designated in that system. So be prepared with whatever systems you have, be ready to deploy them. Think big, order big, like we talked about in the last slide. It's going to be easier to send people home having not done anything than to have to wait on an ambulance for a critical patient. So get them coming, and if you have to, call them off or cancel them or send them back after they get there. Think about supply and staging areas. So if you have 8 ambulances coming in, you want to have a specific spot they go to. You want to have a specific person that's in charge of that spot so that they can coordinate getting them through efficiently and effectively. Prevent freelancing. Now, freelancing is going to be, let's say that you are on some ambulance ABC someplace and you hear in a neighboring district they've got a school bus that rolled over and they're going to have multiple patients. Freelancing is when you just go free will, you've not been dispatched, and you try to go do your own thing. You want to prevent that from happening. You want a very organized and coordinated attack on whatever the incident is. Have some personal tools such as tactical worksheets, whatever you can utilize to keep you organized. Try to get these systems put in place before the incident ever occurs so that way you're prepared. So again, and we've already talked about it, that senior person arriving first on scene is going to assume the incident command. You're going to be directly responsible to oversee the medical aspects and all safety of all personnel. So anybody that's coming in, you got to make sure that they don't get put into harm's way. If it's a larger scene, then you're going to want to designate area supervisors. So you may have a triage supervisor, you may have an extrication supervisor, you may have a treatment supervisor, you may have a transport supervisor, but it just depends on the situation, number of patients, the number of resources that you have. Try to work closely with your fire and police commanders. You may enter into that unified command system. Keep uninjured people from becoming injured, so keep people out of harm's way. And with that, you may need to restrict access to the scene. And it's going to be up to that incident commander to determine who gets access, what that access is. The part that's easily missed in these type of situations is the psychological aspect. Psychological first aid, it may be necessary on the scene of an MCI. So you may have this batch of patients that you have to take care of because they're physically injured, but you may also have this batch of patients that you have to take care of from a psychological standpoint, whether they've been exposed to something horrific, whatever the case may be. You need to kind of have an area for them to go to. Don't attempt to engage in the psychoanalysis of things. Just be open and honest. Don't lie to them. But sometimes just that open honesty, um, encouragement is really going to go a long ways with these patients. The other thing to think of beyond the people involved that might be coming out is over a period of time, you have to worry about the emergency responders as well. So if you have an emergency responder that breaks down at the scene, they're no longer an emergency responder. They're a patient for you as well. Once the scene is over, you may have to do critical stress debriefing to discuss the incident. It's a whole long process in itself that you need to have experience in dealing with, but you need to have those stress debriefing counselors available if possible. Some of these branch functions that you need to think about if you are the incident commander, areas that you may have a need for: extrication, exactly as it is, if you need to extricate patients from point A to point B, or from the actual area of contamination, whatever the case may be. You may have a specific group that is just going to deal with extrication. You're probably going to want to have a staging area where any incoming apparatus come to. They sit in the staging area until it's deemed whatever their job is on scene, and then they're moved from the staging area to the scene. You're going to want to have a triage area where patients come from the initial incident to you. You triage them and then determine what level they are, what transport priority they are, so that they go out in a systematic fashion. Then you might want to have a treatment area. So the patients go to the triage area, get triaged. If there's not an ambulance immediately ready to transport them, they go to the treatment area where they can start receiving that frontline treatment and care by the EMS providers until an ambulance becomes available to transport them. Then you're going to want to have a transportation area. This is going to be where they move from the treatment area and they actually get physically transported to the hospital. You're also separately going to want to have a rehabilitation area, kind of like we talked about earlier in the chapter with the hazardous materials, an area for responders to go to rehab and kind of just get a once over before they go back. Specifically talking about triage now, the goal of triage is to afford the greatest number of people the greatest chance of survival. So that means by using a systematic approach of moving the most critical patients out first to the least critical patients out last, in theory, you should save the most patients in the long run. If you move out all your green patients first, all your red patients may end up dying before they get to the hospital. So it's kind of just this systematic approach. Who do you want to have overseeing the triage area? You want your most knowledgeable EMS provider is going to become that triage supervisor. It needs to be somebody that has great composure, can work well under stress, and can work rapidly so they can move from patient to patient to patient to patient triaging them, getting them tagged appropriately so that they can get the care in the most efficient manner. All right, let's move into the actual triage process. This will be something that hopefully you never have to do in your career, but if you do, you need to have the knowledge because it's going to be easy to get lost in the moment. So the first thing that you need to understand when it comes to the actual triage process are the different priorities. And this is going to be 4 different priorities. So priority 1, or what we would consider red, is considered treatable life-threatening illnesses or injuries. Priority 2, which would be yellow, is going to be serious but not life-threatening illnesses or injuries. Priority 3 is going to be green, which is walking wounded, and these are going to be the patients that can walk. Doesn't matter if they can get up and walk, they are initially going to be considered priority 3. Priority 4, which is sometimes also priority 0, depending on the triage system, and the color denotion for it is black, is dead or fatally injured. Their game's over. START triage is kind of the standard for triage, and it stands for simple triage and rapid treatment. It should be a very speedy, it is simplistic, and is easy to apply to the patient. It's just not a challenging system. There are 3 main components that you have to use in the START system, and the easiest way to remember it is breathing, pumping, thinking. So respirations, pulse, and mental status. These are going to be the 3 assessments that you perform in a rapid fashion to determine what priority they are at the initial triage. Okay, the first step to this START triage. Are they able to walk? If the answer is yes, they're priority 3. If the answer is no, then you move on to check their respirations. So basically, if you get to one of these scenes, the first thing you're going to do is scream out, if you're able to walk to me, come to me. Anybody that comes to you, they're automatically a green. Doesn't matter what they look like. They could have big lacerations all over. They could be missing a hand. They're still technically a green at the start because they're able to walk to you. Now, when you reperform the triage at secondary triage, their condition may change because now maybe there's a pumping issue or something else with it. But initially, they're going to be a green if they can walk. Priority 3, and if they're not able to, then we move on to respirations. Okay, quickly here. Your job when you triage is to triage and triage quickly so that you can get through everybody and then use that information to determine your needs, use that information to pass it on for what different priorities you have. It's easy to get tunnel visioned, it's easy to get to a patient, and then before you know it, you're doing this, this, and this for the patient, and you're not triaging, which is what your job is. You have to be a very focused person to be in charge of triage and understand that you're going to spend just a few seconds with each patient and you're going to move on. Doesn't matter. Doesn't matter what you think. Doesn't matter what you feel. You have to be able to triage, move on. There are 3 exceptions that you're going to stop and rapidly take care of the situation before you move on. And that is airway. If you need to open the airway to insert an oropharyngeal airway, you can stop to quickly do that. If there is active profuse bleeding, you can quickly apply pressure to the bleeding to try to control it. And if you need to, you can also elevate the extremity. Beyond that, you go through the triage process and you move on. Okay, so you started the triage process. They're not able to walk. The next thing you do is assess their respirations. Breathing status is always first in the triage process. If they're breathing, but their breathing is greater than 30 respirations per minute, they are automatically a priority 1. They are going to be a red. They have breathing issues. If they are breathing and their respiratory rate is less than 30, then you move on to the next step, which is to check their pulse. So basically what you're trying to do here is, okay, I've reached the point where I can classify them. I'm done with them. They're classified. If not, you move to the next step. Okay, let's say that you assess their breathing. They're not breathing. What do? Okay, you position their airway and you recheck their respirations. So now you've repositioned their airway. They're still not breathing. And attempts to open the airway does not have them spontaneously start breathing. They're category 4. They're dead. You're going to move on to somebody that you can save. This is the absolute hardest part of the triage process, because if they were the only patient, you might work them. You might give them every chance that you possibly can to save them. But because the nature of a mass casualty incident and the fact that you're trying to save the maximum number of patients possible, you're going to have to make very difficult decisions to say, this one's not breathing, they're dead. Maybe there's a 1 in a billion chance that you could have saved them if you would have stopped and taken care of them. But the probability is you have 2 reds further down the line that now died because you stopped. So, like I said, it's very challenging. Your job is to triage, determine their category, and move on. No matter what, it's going to be hard. Okay. The next step here is going to be assess the radial pulse. If they are unresponsive, not breathing, no pulse, priority 4, they're black, they're dead, move on. If they're breathing, but there's no radial pulse, they're a priority 1. They are going to be a red. They are going to be a critical patient that's going to come out of there first. If they are breathing, they have a pulse, good skin signs, and their cap refill is good, then we're going to move on to check their mental status. So next you're going to assess their level of consciousness. If they are alert, they are going to be priority 2. If they are altered mental status, then they will be priority 1. So like we've discussed, we used the breathing, pumping, thinking. If any of those have inadequacies, they're going to be priority 1. And then depending on what you find through the process, they'll either be 2 or 3. If they're walking, they're 3. Anything else that doesn't fall into the 1 is going to be a 2. Now, once you have triaged the entire field of casualties once, now you're going to move your way back out to the walking wounded, because these were all greens initially, but now you need to go through them a little bit closer, because some of them may end up being 2s, or potentially they could degrade down to 1s if they have a change in conditions. So you're going to work your way through the process with them again, utilizing the respirations, pulse, mental status to determine if any of those 3s need to be upgraded to 2s or 1s. Generally speaking, you can always move a patient up, so a 3 can become a 2 can become a 1, a 3 could become a 1, but you're not going to move down. A 1 isn't going to all of a sudden become a 3. Once they're a 1, they're a 1. They're going to be treated as a 1. Use the process, use it quickly, and it's a very efficient and effective tool to work your way through a large number of patients rapidly to determine what resources you need, what treatment you're going to need for these patients, and you're going to really maximize the number of patients that you can save. And I kind of talked about this as we went through it. Priority 1 is going to be the most serious alive patient, and they're going to be red. Priority 2 is going to be a patient that needs attention but doesn't need immediate attention. They're going to be yellow. Priority 3 are the people that can wait. They're going to be green. And then priority 4, or potentially priority 0, they're going to be black. They're going to be dead. SALT is also another version of assessing and triaging at a mass casualty incident. It's a newer system that's gaining popularity and acceptance in the EMS system. But basically SALT is the acronym for Sort, Assess, Life-Saving Interventions, and Treatment Transport. So the first one being SORT, very similarly to the START triage, you're going to announce anybody that can walk, move towards me. These are going to be your lowest assessment and treatment priorities. Next, for those patients who remain, if you need help, wave your arm, move your leg, somehow acknowledge that you hear me and understand. If they can understand and follow those commands, the way they look at it is this is going to be the next level of patience. Finally, those who have not walked and who could not acknowledge you, they're going to be the most critical level of transport, or they're going to be the deceased patients. Then you move into your assessment and life-saving interventions. They kind of go hand in hand. So once you assess and identify a life threat, the life-saving intervention you can provide should not take longer than a minute. So if you have to do something like put a tourniquet on a patient, that's an acceptable practice. It's still a matter of being able to move through the patients quickly and assessing them, determining their category so that you can keep moving through the process though. Treatment and transport would be the final thing. You're going to give them the triage tags, and then you're going to transport them most critical to least critical, very similarly to the START process, just a little bit different mindset on how you look at things. As far as actually coding these patients, we're going to use the SALT and the MUC triage criteria, which the MUC stands for Model Uniform Core Criteria, and it's utilized for mass casualty triage. Okay, so the first one being the immediate, which is going to be the color code red or the priority 1 that we learned about with the START. These are going to be the patients with severe injuries who are likely to survive with treatment. So the 4 questions you have to ask: does the patient have a peripheral pulse? Is the patient not in respiratory distress? Is hemorrhage controlled? And does the patient follow commands or make purposeful movements? If you answer no to any of these, they're tagged as immediate. So they're going to be coded red. Tier 1, you want to move them, immediate patients, to that casualty collection point first so that you can get them definitive care and get them moved to the hospital as quickly as possible. Now the next tier, which is yellow, priority 2, however you want to look at it, this is going to be the delayed patients. And these are the questions that you're going to need to ask. These are the serious injuries, but they're not immediate. They don't need to get out right away. Does the patient have a peripheral pulse? Is the patient not in respiratory distress? Is the hemorrhage controlled? Does the patient follow commands or make purposeful movements? If you answered yes to all with significant injuries, then they're tagged as delayed. And then just like the other one, the minimal green priority 3 patients are going to be those with minor injuries. Anything minor, if they can walk to you, they're going to be tagged as green. If something changes, you can always reassess them later and retag them later. But for the initial purposes, they're going to be tagged green. Dead, black, 0, 4, however you want to look at it. These are going to be injuries incompatible with life or without spontaneous respirations. So is an adult patient not breathing after the EMT opens the airway? Is a child patient not breathing after the EMT opens the airway and gives 2 breaths? So you're giving a little bit more to the child here. If you answer yes to these, tag them dead, they remain in place, you move on to the next patient. One thing that this system with the SALT and MUC triage criteria adds in is a different color, and it's classified as what's called expectant. They're going to be gray. They're going to be unlikely to survive given the available resources. So again, very big challenge if you're the triage person, because this person's alive and you're chalking them up as being dead. So you're kind of putting them on the back burner. Hey, they're probably going to die. If they're still alive after we get through everybody else, we'll give them a shot, but we're not going to burn a bunch of resources now because saving this one person might cost us to lose 3 others. That's the mentality that you have to have when you're thinking about this. So you're only going to give these patients treatment after the immediate patients have been moved forward. And your book utilizes the example of a patient with severe burns covering nearly their total body surface area. They might still be alive. Even if you get them to the hospital, they're probably going to die of infection and other complications soon. So if they die on scene, they die on scene. You want to take care of the ones you know you can save. If you come back to them and you can get them to the hospital, so be it. But again, it's going to be very tough on you as the triage person to make that determination because you see them breathing and you're classifying them as probably going to die. Now, as you get more resources, more personnel on scene, and you can set up more effective ways of doing things, you're going to have secondary triage and treatment areas. Secondary triage is performed at the patient collection point or the triage area, depending on your resources. If you're able to separate them into treatment groups based on their priority level, that's going to be best. So you're going to have an area where all your red patients go. That's where most of your physical resources are going to be because you're going to be performing life-saving interventions on them. And then you might have an area where your yellows go, and then you're going to have an area where your greens go. If you have the staff and the ability, best practice is to have a treatment supervisor at each of these areas. So one person oversees each area. As they get assessed, as they get treated in those areas, they may get recategorized and moved around depending on if they get better or worse. It just is all very situational. You can kind of see though that it's going to take a tremendous amount of staff and a tremendous amount of resources in a very large scale incident to make it work properly. You're going to have maybe some ambulances there that never transport a patient, and they're strictly your supply ambulances because you need bandaging, you need sterile water and saline and different things depending on what you're taking care of. So again, that's where earlier on where we talked about, aim big, get plenty of resources there, because even if you have 15 patients and you know you're going to transport 15 patients, you may need 18 ambulances because you may need 3 ambulances just to supply you with the equipment to take care of people while you're getting them moved around. So always be thinking ahead, understand the situation, understand the stress that goes with this, and then do the best you can. So we've discussed and gone through the triage and the treatment, how to take care of patients there. Now let's spend a minute talking about the transportation and the staging logistics. So once these patients are assessed, triaged, and treated, they're going to be transported according to their priority. So reds, yellows, then greens. How you transport them is going to depend on what your resources are. If you can get a bus, a school bus, a city bus, whatever the case may be, and take 12 greens to a hospital that's further away, that's going to have the availability and resources to take care of that many patients, that's a really good possibility for you to do. The staging area is where the ambulances and these ancillary units, whether it's a bus, a van, whatever the case may be, that's where they're going to go and sit and wait for the patients. So it might be 2-3 blocks away from the scene. You have to determine where that staging area is going to be, and you're going to have somebody in charge of that staging area. The staging supervisor keeps track of what resources they have and what personnel they have. If they have 3 BLS ambulances and 5 ALS ambulances, they're going to want to use the ALS ambulances first to take care of the red patients. Maybe the BLS ambulances takes care of the lower level patients. They'll work hand in hand with the transportation supervisor who's going to be in the treatment areas, arranging transport of the patients from the scene to the hospital. So basically what's going to happen is the transportation supervisor is going to be like, I got a red that's ready to go. Staging supervisor is going to say, hey, Med Unit 3, you're up next. You go to the scene. You're going to take a red patient. One thing that you have to think about is overwhelming a hospital surge capacity could bring poor outcomes. So if you take too many red patients to the same hospital, they may not have the capability to take care of all of those patients effectively, and somebody may end up dying because of it. So you need to understand where you're located and what your resources are. For us, we have a hospital 20 minutes to the north, 20 minutes to the west, 15 minutes to the east, and we have 2 or 3 hospitals, 20 minutes to the kind of southwest. So by diversifying and sending those patients in different directions and not overwhelming one with all of the critical patients, you're going to create better outcomes for your patients. The other thing that changes in this type of situation is the communication with the hospitals. So we've taught you earlier in the chapter, you pick up your patient, you get things going with your patient, you call the hospital, tell them you're bringing them to the hospital, you give them a full radio report, get them into the hospital, hand off patient care, give them a verbal report face-to-face. It's going to be different in this situation. So your receiving hospital needs to be contacted early, whether that's by the incident commander or if they have enough staff there and a transportation officer is named early on, they can take care of this responsibility, but they need to contact the facilities to determine the capabilities and keep them updated on the expected patient counts. So if you have 30 patients, you want to contact the 4 or 5 hospitals around you. Hey, I have 30 patients. What can you take? They might tell you, I can take 3 reds, 5 yellows, 6 greens. And then through your organization skills, you're going to be able to say, all right, this hospital can take this, this hospital can take this, this hospital can take this. And then as the transportation officer, you have to work your way through those, sending them the patients as you pull them out of your treatment areas. Now, when you're contacting the hospital, it's actually the transportation officer that's going to contact that hospital, not the individual EMT. So as the transportation officer, say, calls up Med Unit 15, they say, Med Unit 15, you're taking this red patient to Mercy Hospital. That transportation officer is going to call Mercy Hospital. Med 15 is inbound to you with a red patient and just a very brief, to the point, no vitals, no real details, and the crew's only going to take care of the patient, take them to the hospital, drop them off. You're not going to want to overwhelm the hospital with a bunch of radio reports, have somebody tied up just taking radio reports. And generally, too many patients, there's going to be too many patients to allow for a good radio report. Your job is to get them there, and then you might have to come back to get the next one. So you want to do things as quickly as possible. Again, only the basic information is what you're going to pass on. So just kind of thinking about an MCI, and I can tell you I have been part of a handful of these, ranging from school bus accidents to multiple vehicle accidents with 7 to 9 patients that I've dealt with. And then I've been not directly part of the command structure, but I've been a responding ambulance to a couple scenes where there's been dozens of patients. And for me, I also was able to go with our fire department down to Hurricane Katrina and work through some of that process. So I've seen and dealt with a lot of these MCI situations. So just kind of take a moment to reflect. What would you do if you came upon a school bus accident and there was 18 kids in there and only 4 of them were outside of the vehicle? What would be your plan of attack? You have to take incident command. You have to work your way through the process. So composure is key, communication is key, delegation is key, good triage is key. If you can do those things, you'll have a successful scene. It's going to be very challenging because you may be put in a situation where you have to pick and choose who lives and who doesn't live. And that just plain old sucks. But it's the reality of the job that we might get thrown into as EMS providers. and you have to just do the best you can and understand that what you did maybe saved somebody that wouldn't have otherwise been saved. So chapter review, kind of scroll through the slides, or it's going to scroll through them for you, I guess. Make sure to read the chapter. There's a lot to both of these sections. Really, you could have a whole class on just mass casualty incidents, and there are whole classes on hazardous materials. So this is basically just giving you not even the Reader's Digest version of either one of these. It's just giving you a basic understanding of what you might run into and what you might see. So look through the chapter as you get your license, as you get your career going. Look for classes that can maybe educate you a little bit more on both of these. They're rare. You're not going to see them every year of your career. You might not even see them at all in your career. But if you do come in contact with either one of these situations, you want to be educated and you want to be comfortable with the situation so that you can do the best job possible.